Welcome to PIPADOR Revise in 5, a series of short focused revision tutorials for MRCOG. This tutorial is on the topic of sarcoidosis in pregnancy and makes reference to the recent TOG article published in 2024. Sarcoidosis is a systemic disease characterized by the presence of non-caseating granulomatous lesions. It predominantly occurs as a multi-system disease, and the etiology is uncertain, although infectious and genetic contributors to its pathogenesis have been proposed. The overall prevalence is 19 per 100,000, and in pregnancy the prevalence ranges from 1 in 2,000 to 1 in around 10,000, although more recent data suggests lower rates. The peak onset is in women aged 20 to 40 years old, and Black African women are more likely to experience severe disease. The mortality from sarcoidosis ranges between 5 to 10%. Pulmonary involvement is seen in 90% of patients, predominantly interstitial lung disease with a risk of pulmonary arterial hypertension. Skin disease is the most common extrapulmonary manifestation. Up to 50% of patients experience cardiac symptoms, typically syncope, due to infiltrative myocardial disease, and this can cause life-threatening arrhythmias in between 2 to 7% of patients, which sometimes requires an implantable cardioverter defibrillator, or ICD. Central nervous system involvement with sarcoidosis occurs in 5 to 13% of cases, and this is most commonly in the cranial nerves. The diagnosis of sarcoidosis is primarily one of exclusion, but is based on 3 predominant criteria: clinical presentation, the presence of non-caseating granulomas in tissue samples, and the exclusion of other granulomatous disease. Initial investigations depend on the presenting feature of concern. For suspected pulmonary sarcoidosis, chest imaging includes chest X-ray, high-resolution CT, plus or minus bronchoalveolar lavage, and transbronchial biopsy. For suspected cardiac involvement, an ECG, echocardiography, or cardiac MRI may be used in pregnancy. For CNS involvement, an MRI brain may be performed, and electromyography, or EMG, can be used to diagnose myopathy secondary to sarcoidosis. In non-pregnant patients, serum angiotensin-converting enzyme or ACE levels can be used for monitoring disease. However, ACE levels can be altered in pregnancy and therefore cannot be used in pregnant patients. Pregnancy shifts immune responses towards T helper 2 regulation, suppressing T helper 1 mediated inflammation, and this typically lends itself towards disease remission or stabilization, so the majority of patients improve or see no change in their symptoms. However, for patients with severe disease, there is an increased risk of deterioration. Sarcoidosis in pregnancy is associated with a number of risks. These include a higher risk of preeclampsia, fetal growth restriction, and preterm delivery. There's also a high risk of deep vein thrombosis and pulmonary embolism, which has the highest adjusted odds ratio of around 6. Caesarean section is also more common, as well as postpartum hemorrhage. For patients with interstitial lung disease, pregnancy is often well tolerated. However, these patients may show an increased need for oxygen support and may need a caesarean birth. They have not, however, been shown to have overall worse pregnancy outcomes. Pre-pregnancy conception planning is essential in patients with sarcoidosis. Ideally, the disease should be stable before conception, and there should be an individualized MDT discussion of risk if the patient has severe interstitial lung disease or symptomatic cardiac disease. A baseline assessment should include a full blood count, U's&E's, LFTs, as well as calcium and ACE levels, and a baseline ECG. An echo should be arranged if there is pre-existing cardiac disease, or 24-hour Holter monitoring if there are palpitations. Medications should be optimized, and those contraindicated include methotrexate, which should be stopped at least 6 weeks prior to trying to conceive, mycophenolate, which should be stopped at least 4 weeks before trying to conceive, and leflunomide, which should be stopped 11 days prior to trying to conceive, and consideration should be given to a cholestyramine washout. Medications which are not contraindicated include corticosteroids, azathioprine, and anti-TNF biologics such as adalimumab and infliximab. Antenatally, these patients should be on aspirin, as well as low molecular weight heparin for VTE prophylaxis. Calcium and vitamin D supplementation should be avoided due to the risk of hypercalcemia. Serial fetal ultrasound should be arranged to screen for fetal growth restriction, and there should be active investigation if there are any symptoms of tachycardia or palpitations. Thyroid function tests, ECG, 24-hour Holter monitoring, and an echo would be advised. For intrapartum care, individualized MDT timing of delivery is recommended. Vaginal delivery is often possible, and caesarean is not routinely recommended. For women with severe disease or cardiac involvement, caesarean should be considered, or at the very minimum, a shortened second stage. Careful fluid management in labour is recommended if there is interstitial lung disease to reduce the risk of cardiac failure. In the postpartum period, there is an increased risk of disease flare. Maintenance therapy should be recommended to be continued or resumed. If the patient is breastfeeding, safety profiles of the recommended medication should be considered. The patient should also receive advice regarding postnatal contraception according to their wishes. Here is an example of an SPA sample question on sarcoidosis in pregnancy. Please try our online MRCOG Part 2 revision question bank at our website, pipidor.co.uk.